Comparative analysis of prevalence of apical periodontitis in smokers and non-smoker using cone beam computed tomography by Dr. Balto et al. In 2018. So the aim of the study was to compare the prevalence as well as the size of periapical lesion among smokers and non-smokers using CBCT. The information obtained may help to clarify whether or not smoking is a risk factor for apical periodontitis and thus is expected to be useful in understanding the immune response in apical region. So it's a cross-sectional study conducted in King Saud University with an informed consent was obtained from each patient, the CBCT data from the archive of the radiology department. The inclusion criteria was only male patients over 18 years of age with a retrievable CBCT dataset acquired during a consecutive period from January 2008 to March 2016, which had more or equal to 6 teeth apices included in the dataset. The reason for referral and the type of the treatment requested were not included in the data analysis. Patients who agreed to participate were scheduled for a clinical examination, which was performed after they gave the written consent. During the clinical examination, medical history, smoking history were obtained, and the smoking history of the patient was identified whether non-smokers or smokers as active or passive. Patients were considered passive smokers if they were exposed to environmental tobacco smoking for at least an hour per week. Because of the lack of evidence on a well-established biological limit, this threshold was chosen arbitrarily to match the threshold used in a comparable larger population study conducted by Howard et al. In 1998. Patients who were found to be smokers were asked about the number of years of exposure prior to taking that CBCT and other recorded clinical findings as any signs of previous dental trauma, number of teeth decayed, missed or filled teeth index scores, and also the oral hygiene index for the patients. The CBCT dataset were converted to digital imaging and communication and medicine DICOM format and imported into a 3D image reformatting system. The examiners were an oral and maxillofacial radiologists with 8 years experience in reformatting and interpreting the CBCT images and a consultant endodontist collaborated with the radiologist in interpretation of the CBCT images. The examiners were blinded to the patient's smoking status. Each tooth root was examined individually by obtaining transverse cross-sectional images and parasagittal image parallel to the long axis of the root. The thinnest CBCT slice thickness possible were used. A periapical lesion in this study was diagnosed when disruption of the lamina dura was detected and a hypodense area associated with the radiographical apex was more than 0.5 millimeter or approximately twice the width of the periodontal ligament space and not parallel to the root outline on one or more roots or at least 2 planes of the CBCT images. The presence or absence of endodontic filling was also determined for each tooth from the CBCT image. So a total of 76 patients were included in the study. However, 30 patients were excluded due to presence of systemic diseases, history of previous trauma, artifacts in the CBCT images, and suspected fibrosis disease. So the number of the patients in the study were 46. 19 were smokers with 41.3% and 27 were non-smokers with 58.7%. So the age, DMFT scores, and the percentage of the root filled teeth and the oral hygiene scores were found to be similar between the two groups. The CBCT data sets concluded that 327 teeth with 45.5% was examined with the smokers group and 273 teeth with 45.5% in the non-smoker group. The prevalence of apical periodontitis was 13.9% in smokers and 14.3% in non-smokers with no significant difference. And the number of smoking years before taking the CBCT was not correlated with either the percentage nor the size of the lesion presented. So in conclusion, while smoking is considered a risk factor for marginal periodontitis, there was no differences between smokers and non-smokers in terms of apical periodontitis.